Hello, everyone. My name is Steve Baggus. This is a presentation for patient education on core muscle injuries. I think the first thing to know is that this is to not call this a sports hernia. It is a core muscle injury. It has involvement with the rectus abdominis and the core muscles and the adductors. There's really no hernia involved, so it's important to move away from that term. Of all sports injuries, 2 to 5% of them have been shown to be core muscle injuries. The most common sports involved in are soccer, ice hockey, field hockey, and Australian rules football. The occurrence can be either acute, chronic, or an acute injury of a chronic condition, meaning they've had some chronic groin or core pain and they have a flare-up or a direct injury to that area while experiencing the chronic condition. It's more common in males than females. And there's several different conditions and injuries that can be labeled as a core muscle injury. So it's important to really evaluate the entire athlete and uh, educate them on what they're feeling and kind of learn that way. The bony anatomy is the ilium, the ischium, the pubis, the sacrum, and the coccyx. As you can see, here is a good image of the pelvis with the bones involved. The soft tissue anatomy are the pubis symphysis, rectus abdominis, and the rectus aponeurosis, where it begins to connect and attach onto at the pubis symphysis. The adductors involved are the pectineus, the adductor brevis, the gracilis, and the adductor magnus. It's also important to involve the inguinal ring and the obliques. Here you can see the different muscles and their anatomy and their attachment points within the core. The causes are typically overuse, or there is a muscle imbalance between the rectus abdominis and the adductors. The rectus abdominis and the adductors are pretty much in opposition of each other while performing athletic movements. So if there's a muscle imbalance there, that's what can cause the flare-up and essentially the damage to the area. Also, if there is a core muscle or lower extremity weakness, flexibility issue, or even if there's a coordination issue, if they can't control their body and space very well, they're left susceptible to this injury. And also if they have rotational instability, which kind of relates to controlling their body in space. If they're not strong enough to be doing the movements they're doing in sport, they definitely can succumb to this injury. The signs and symptoms, typically they can present with an adductor strain with point tenderness at the attachment site and also with resisted adduction. Or an iliopsoas strain with point tenderness in the abdomen, kind of over the oblique area with a resisted sit-up, and the rectus abdominis strain with a point tenderness at the distal attachment with resisted sit-up. Also, if there's hip adductor origin tenderness. So kind of examining the attachment points, if there is pain with movement or with resisted muscle testing, it's a sign that there could be a bigger problem. The typical imaging done for this injury are an X-ray in the anterior posterior pelvis, and then also an anterior posterior view and a lateral view of the affected hip. meaning there's typically one side of the hip that is having more symptoms than the other. The findings that they're looking for with the x-rays are FAI, osteoarthritis, osteitis pubis, or an avulsion fracture. In the advanced imaging, it's typical to get an MRI, and with that, they will select the athletic pubalgia series. With this series, they get the entire pelvis. The views are coronal, sagittal, and axial planes. And there's also a coronal oblique view, which is able to see the rectus and the adductor attachment at the pubic tubercle. This view is taken in very shallow cuts throughout the pelvis so that they can really examine where or if there is a disruption in the muscle or at the attachment point or the aponeurosis. For the differential diagnosis, it is important to rule out a lot of things. As I said before, there's a number of injuries that are called a core muscle injury or, can kind of present as one. So there's adductor strains, osteitis pubis, iliopsoas strain, or even bursitis over the iliopsoas, stress fractures in the pelvis, or an avulsion fracture of any of the muscles involved. And oftentimes there's groin pain associated with a hip injury. So, try to clear the hip right away for a labral tear, femoral acetabular impingement, or even snapping hip. And also there can be nerve compression through the muscles there. The conservative treatment, which is recommended first by the majority of physicians, consists of rest, ice, compression, and then NSAIDs. The therapeutic modalities can be helpful, whether it's electrical stimulation or ultrasound. And it's been shown that soft tissue mobilization is also very helpful in this area, whether it's active release therapy, Graston technique, or even deep tissue massage. Also focus on exercises of the adductor, the core, and hip strengthening. It's important to focus on the muscle balance and even the endurance of the muscles, being able to actively move their body throughout the time necessary to compete in their sport. And that rotational forces can also play a role. So trying to work on that without inducing pain. And then also flexibility through all planes of motion for the lower extremity and the core. And it's also been helpful to involve some joint manipulation, whether it's the hip, the pelvis, the sacroiliac joints, kind of clearing space for the pelvis to move better and be a little bit more fluid can be helpful. So while the conservative treatment is going on, active rest is important. Basically avoiding the offending movements for 8 to 12 weeks. So trying to limit their pain as much as we can while strengthening them is the goal for this conservative treatment point of time. And then once you're thinking about returning them to play is once the athlete can perform the sport-specific activities without pain. Basically introduce the movements that were hurting them before and, trying to get them to be able to do those movements effectively. There's also a number of injections that can be done, whether it's corticosteroid, platelet-rich plasma, or prolotherapy. They look to insert those kind of depending on where the origin of the pain is. It could be at the pubic tubercle, the rectus insertion, the adductor insertion, or even in the hip joint to kind of rule out any hip involvement. And then there's surgical treatment. An exploration surgery and a repair is really only suggested after a failure of a conservative treatment plan. And depending on the level of the athlete, the doctors may be willing to go into surgery a little bit quicker, especially if they can see a full disruption via the imaging. It can be done either open or laparoscopically. They will repair the adductor or the abdominal muscles. And it's been shown to be more successful if both of the opposing forces causing the disruption are addressed. If you only look at to fix one area, then it doesn't have such a high rate of success. And it's been shown to be 63 to 95% success rate. And the laparoscopic surgery is a quicker return to play. And returning to play post-surgery, typically most doctors suggest beginning to return to training at 4 weeks with a full return to play around the 6-week mark for a laparoscopic operation, and it is in 18 weeks if it's an open operation. But unfortunately, more research really needs to be done for an evidence-based return to play protocol. Most of the protocols are just kind of decided on by the doctor's preference and experience with the surgery. The typical time frame looks like from day 1 to day 21, you're really working on range of motion, flexibility, and then a biomechanical education, teaching them how to move properly after the surgery so that this issue doesn't come up again. And we can begin running and sprinting at day 21, the 3-week mark, and then begin cutting at the 6-week mark when they can begin to return to play. And here are my references for this education. Thank you very much.